This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast. It is February 2026. Ryan, it is finally here. After so much talking about it, we've made it 10 years.
Hopefully not too much talking about it.
No, there was a lot of talking about it.
We are, yes. Finally at the 10-year mark. And now you don't have to hear us talk about it. Unless you want to hear us talk about it next month. Yeah, remember how last month we hit the 10-year mark?
Well, yeah, because technically I started the podcast 1 month prior to you. So technically my 10-year anniversary was last month. But our 10-year anniversary together is February.
Yeah, I mean, that's how you count it, right? You wouldn't like lump in your ex-wife with your current wife and say, look, it's our 15-year anniversary, honey.
My amount of years I've been married. Yeah, no, that probably wouldn't go.
But all right, it's the anniversary of how long I've been married.
Yeah, let's move on.
Yeah.
Let's talk about some medicine,
do some science.
Our first article: analgesic and analytic effects of virtual reality and classical music therapy on tension headaches, a randomized controlled trial, and the lead author is Safa Dalmez. So, I mean, we see a lot of headaches in the emergency department, and some of them may be categorized as tension headaches. And we have a useful amount of pharmacological tools we use to treat these headaches. But these authors wanted to look at some adjunctive therapies. Most notably here is how does virtual reality and classical music help with relieving tension headache? And so what they did is they randomized patients coming in with what they described as a tension headache, one of two groups. The first group, control group, got a form of IV NSAIDs alone, and then the intervention group got that IV NSAIDs as well as what they described as immersive virtual reality, which they put on virtual reality goggles. And with this, classical music was delivered. They described the scene as a tranquil forest scene with a flowing river, a suspension bridge, and sunlight reflecting in a way that does not disturb the eyes. And then, and then the classical music was a selection that was derived in an arrangement that was supposed to feature relaxing works. Importantly, both groups got stuck in a dark room, and one was stuck into a dark room and got the IV NSAIDs alone, and the other one was stuck in a dark room and got the IV NSAIDs plus this virtual reality cocktail. And they basically looked to see how their pain score changed over time. The primary outcome was change in VAS score from baseline to 120 minutes between the two groups. And then they had multiple secondary endpoints, looking at time measurements at 30, 60, 120 minutes, need for rescue medication, side effects, so on and so forth. So they randomized a total of 140 patients, and both groups improved over time. However, they did show that the intervention group experienced significantly greater reductions in pain score throughout this time period, both at 30, 60, and 120 minutes. And this reduction was substantially higher in the patients who had the virtual reality setup. They also showed that the patients who had the virtual reality setup got far less rescue medications, about 45% in the control group, and only 2 patients or 2.9% in virtual reality. So, I mean, I think this is an interesting idea. Obviously, there's a lot of questions on how this kind of can be extrapolated to your emergency department. And then the other thing is really one single dose of an NSAID really a good control. We have lots of other medications you give people to treat their headaches. Will this virtual reality work as well if you gave someone, a more effective headache cocktail, including metoclopramide, droperidol, so on? And so that's unclear. And then the next thing is this even really possible in most of our work? Because, our headache patients don't get put in a dark room. They're usually in the hallway in a noisy ED. And I'm not sure this virtual reality setup works as well in those kind of.
I mean, you could argue that the virtual reality setup is even more necessary in that hallway environment. I'm not in the hallway of a busy emergency department. I'm in a babbling brook. But which is it? Is it the music or is it the virtual reality therapy that's providing this advantage here? We don't know. It could be either. I mean, there's lots and lots of studies showing that music is beneficial. Heck, there was even a study published a couple days ago where music was valuable for reducing like perioperative adjunctive pain control if you just had it playing during their surgery. Synergistic effects, music, propofol. I don't know, but I mean, there's a lot of face validity to this. Relaxation and nice and soothing music makes a lot of people feel better. As you say, the rubber has to hit the road somehow. How can you actually operationalize this in the emergency department? You say maybe they need an adequate dose of something, but in this case, you could get away with not using something sedating and with some adverse effects and just use ibuprofen ibuprofen and sound. I don't know. Or people could just not come to the emergency department. They could lay in a dark room at home with their ketoprofen and some nice music.
Yeah, I mean, depending on how many kids you have, that may or may not be possible. But
Yeah,
if possible, yeah, you could probably just take some ibuprofen and put on some headsets and earphones, and you get the same effect.
Yeah, I mean, and that's how you start wondering about the generalizability of a population in which they haven't already taken an NSAID, coming to the emergency department before they could still be enrolled and randomized to having an NSAID. So anyway, all right. Well, that was a fun topic, and let's move on to something entirely different. The next article we'll talk about from this issue is called "Does Exposure to Certified Stroke Centers Affect All Communities Equitably? Stroke Patient Outcomes by Community Socioeconomic Status." Our lead author here is Yu Chen Shen, and they're at the Naval Postgraduate School, and it's a fairly simple equity analysis paired with a slightly less reliable outcomes evaluation. The basic question is right there in the title. What sort of access do disadvantaged populations have to certified stroke centers? And how does it affect the care they receive for ischemic stroke? So this is a Medicare claims database data sifting exercise using the time period 2009 to 2019. And there are a couple comparisons being made here. First, there's just what's the percentage a patient in a disadvantaged community has access to a certified stroke center versus a patient in a so-called advantaged community. And then there's the question of when a hospital becomes a certified stroke center in an advantaged or disadvantaged community, what effects does that have? They looked at 2.8 million admissions for ischemic stroke, and as you can readily imagine, patients in advantaged communities had dramatically higher access to specialist stroke. The study period starts in 2009 when thrombectomy was not yet widely deployed outside of research settings. Everyone basically started from zero. By the end of the study period, nearly 80% of advantaged communities lived within 30-minute drive of a thrombectomy-capable center, as compared to less than 40% of disadvantaged communities. These proportions roughly matched access to primary stroke center hospitals remained stable over time. The rest of the study is a little harder to parse and interpret, attempting to pair these newly certified stroke centers with patient outcomes. The differences described are primarily process-related, whether patients received rip and ship thrombolytic therapy, thrombectomy, and whether they got discharged to home at 90 days or 1 year mortality. Overall, as you might expect, having a dramatically lower initial access to stroke centers, adding stroke center certification to a disadvantaged community had a much higher impact than the likelihood of it being admitted to a stroke center. The rest of the process outcomes were less consistent, as were the patient level outcomes. So I think I'd mostly take this article for the first, most reliable observation. Stroke centers are not equitably distributed, which affects access to timely therapy. It should also be noted that proximity is not always a proxy for access, considering the effort made in pre-hospital triage of stroke to ensure patients are matched with capability of the receiving hospital. Then the authors focus on thrombolytic therapy, but we all know the best evidence supporting the value of stroke centers, other than thrombectomy probably, comes in the post-stroke care, prevention of complications, and early rehabilitation. So a fair bit of imprecision here due to the limitations of their method, but overall the basic premise has base validity.
Yeah, I mean, I think it's, when you have a system that's made for making money, then this is what you're going to get versus a system that is made for treating patients. And so, not surprising.
You said it.
All right. Our next article, efficacy of adding intravenous saline to NSAID-based treatment of acute migraines in the emergency department. And the lead author is Yusuf Turan. So we all have our migraine cocktail, and the aspects of that cocktail are based more or less on some evidence. Ryan's, what's your migraine cocktail?
Droperidol monotherapy.
Yeah.
I mean, usually they've gotten paracetamol and an ibuprofen at triage, and then they hit the room, and then it's like, if they're not better yet, droperidol. Yeah.
It's similar to my own. But, they can get quite complex with people going for gabapentin, magnesium, and then often IV fluids are included in my cocktail. And the physiological reasoning here is patients often get migraines when they're dehydrated, and so rehydrating them may improve their migraine. But there's very little evidence supporting the actual benefits of the use of IV fluids in the treatment of migraine. So these authors randomized patients presenting to the emergency department with migraine to two arms. The first arm was NSAID-based treatment with IM diclofenac alone versus IM diclofenac and bolus of normal saline. The patients in the control group did get IV fluid, so the rate was at 10 milliliters per hour compared to a liter over an hour. So there was some form of blinding that it may be unclear if you were receiving your full IV fluid bolus or not. So after an hour, if you still had fluid in your liter bag, it's somewhat easy to kind of unblind. But they essentially looked to see what was the reduction in pain scores over this interval. They also looked at need for rescue medications, length of stay, patient satisfaction. They randomized 128 patients, and 125 of them were included in their primary primary analysis. They essentially saw no clinical difference in the pain reduction between the two groups. There was a small difference in the actual numbers, so the difference between the groups was in the range what we call the minimally important difference, which is essentially pain score difference above which patients will actually notice clinical difference in pain. And so this was within that range where it likely didn't matter. They did note that the patients in the IV fluid group received a whole lot less rescue medications. 42% in the control group received rescue medications, 23.8% in the intervention. Length of stay was actually a little bit shorter in the IV fluid group compared to control group at 19 minutes, which goes against their kind of initial theory that it takes longer because patients have to receive a whole bolus. Now, this was simply because both groups received fluid over an hour. It's just one received only 10 cc's and the other received the whole liter. So you're not really going to be able to test like stay if both groups are receiving a therapy for an hour. All in all, this shows that IV fluids probably don't do much. I think it's hard to suggest that it's completely negative given the difference in rescue therapy. I'd like to see more evidence on this where we will go one way or another. But overall, I think if you actually used a real migraine medication like Paradol, this difference might go away.
Just because we generally don't believe that normal saline has a effect in all patients doesn't mean there aren't a subset of patients in whom it does help their headache, because they do show up dehydrated and nauseated and vomiting, and they have a viral illness or something else that's triggered their migraine. So this doesn't say never use saline, and this doesn't say always use saline. It just means that you can actually probably select patients who are appropriate for saline on your own, and you don't have to do a blank thing one way or the other. Next one we'll talk about is, can the association of the biomarkers GFAP, and UCHL1 predict intracranial injury after mild traumatic brain injury in adults? A systematic review and meta-analysis. Our lead author here is Antoine Puravet, and they are at CHU Clermont-Ferrand. I don't speak French, so butcher that. You've probably heard of these two biomarkers, the GFAP and UCHL1, because they're part of a couple commercial systems aiming to diagnose traumatic intracranial hemorrhage without performing a CT scan. Obviously a noble goal where the radiation cost and resource burden of advanced imaging results are potentially avoidable. This meta-analysis pools the results from 11 observational studies measuring the accuracy of the GFAP and UCHL1 biomarkers and comes up with a final sensitivity of 100% and a specificity of 29%, and then discards the lowest performing specificity study to boost their final estimate to 31%. As with any meta-analysis, particularly ones including studies sponsored by the teams refining these assays, there are going to be some hidden biases among the studies. And in this case, there's issues where these are frequently frozen samples analyzed at a central laboratory, not to mention specific exclusions and inclusions for the types of patients eligible for these studies. These do not necessarily generalize to the point of care machines being popularized for this application. However, the reason I mentioned this article on the podcast is the systematic review that sensitivity of 100%. And the lower bound on that sensitivity is 99%. But if you just look at the studies included and you take the raw proportions, you get 693 true positives out of 702 cases of intracranial hemorrhage. And that's just a raw sensitivity of 98.7% with a lower bound of 97.6%. So how can you have sensitivity of 100%? There are clearly missed cases of intracranial hemorrhage. This gets into the weeds of statistical chicanery. It boils down to this, you can always fast forward this, but the metaprop package used in Stata software that pools and transforms the results from each included study. And because so many of these small studies report 100% sensitivity, the average of all the included studies is close to this upper bound of 100, and it compresses these and then decompresses them outside of the transformation. It isn't to say their choice for pooling these data is technically wrong, but as you can see, you get potentially misleading outputs when you have a whole bunch of studies that are close to that unity, that 1.0 boundary. If you use something else like a generalized linear mixed model, then you have an output that has face validity in the context of the naive portions. So a bit of a pedantic foray here. A point remains. These biomarkers, despite what this meta-analysis says, are assuredly not 100% sensitive. You're going to always miss 1 to 3 cases per 100. Whether that's clinically important or not, it's another matter. But at least from the face results presented here, you should understand the 100% sensitivity is a little misleading.
Yeah, I think probably the more important part is that awful specificity. And, all the time, like the idea of these is obviously to reduce CT imaging, but almost definitely if this was used clinically, it would increase imaging, right? Because like the threshold to order a blood test is much lower than the threshold to order a CT scan. And so these would get ordered on everybody. And obviously with a specificity like that, it would increase the rates of CT imaging, the We got a lot of work to do here. One is obviously, this meta-analysis is not enough. You need a much bigger multi-center study to show this. And then ideally, you would actually look at rates of imaging when this is introduced to see what happens.
Yeah, the implementation studies are the most important part. And there's one group that's like Orlando Regional Hospital is like the flagship of this in the United States. And I think they are publishing stuff about their implementation, but it's one thing to be the center that's got a champion that's doing all the research and using it, trying to show that you can do this rigorously and use this to make a difference versus what people are going to actually do in practice too.
Right, exactly. Our next article, application-based education of corneal foreign body removal in an emergency medicine residency, and the lead author is Viren Janetti. So corneal foreign body removal is a core skill in emergency medicine, though many of us are not as comfortable as we'd like to be with this skill. In fact, I would say many of us are probably scared of eyeballs altogether.
I'm just old and shaky.
And it's one of these skills which are like many skills in EM that we are supposed to be competent, but we get very few opportunities to actually do this practice. And so these authors wanted to look at the educational ability of a mobile app was built to educate trainees on this skill versus standard education. And so they took emergency medicine residents across all training levels, and they were prospectively randomized. Two groups. First group was called the crossover group or the control group that got initially just standard education materials, including textbook reading, instructions, and so forth. And the second group, which they called the EP app group, that were paired by reviewing the information that was on the app. And then they tested them. And this test consisted of written knowledge assessment and a procedural skills test. There's some great pictures of procedural
a simulated eyeball.
Which has got a little gel simulated eyeball that you're trying to, remove a little foreign body from. And so that was essentially in the initial phase. There was then phase 2, which was the crossover phase, which then both groups got exposed to the EP app, and then they retested them to see how the addition of the EP app helped the control. And they just wanted to look at performance overall between these two groups. And so they had 30 training physicians across 3 recruitment sites, and they initially found that the EP group outperformed the usual care or the usual preparation group in both written assessment and procedural competency. When they crossed over, they showed an improvement in both groups, though the control group improved at a much higher rate than the EP group did. And they got closer to where the EP group was overall in both written and skill. They found that the confidence of the residents increased after using the EP app, both in the control group and the original EP app. Yeah, I mean, this is interesting. Obviously, we have more and more technology. The more we can include this in resident training, I think better it'll be. There's always like the question, are you just like training people to the test, right? Like if I just like teach you the questions are going to be on the test in an app and exactly how to do the procedure the way that it'll graded, you're obviously going to perform better than if I kind of generally give you information. So it's a little unclear exactly how much of that is happening here. But I think the more we can use technology, harness technology to help in our training better.
Yeah, I mean, it's simulation and education. I mean, this is, we do so much that's either in situ or simulated, procedural, competency. This is just one more element of it. Is this the ideal way to teach people? We don't know. These are the authors actually who developed this app that helps teach them. And there's some great quotes in here. It's like, not all information free or open access. The stuff you read on the internet, the educational resources, not all of it's guaranteed accurate. It's like great. There's really funny stuff about how like people should not be using stuff that they just randomly find on the internet and like taking it for gospel. And then reading this article, I'm thinking, how are they not getting enough exposure? We have so many ocular foreign bodies at our hospital. Like they all go to our fast track. Our CNSs are like pros at this. They just they whip these foreign bodies out continuously all day long because we have so much like manufacturing in our city, and they always pop in. And then there's metallic foreign bodies. We take almost everything out unless it's right there in the visual axis. And then luckily we have some ophthalmology support for some of those things. But these Prince of Wales folks in Sutherland Hospital in Sydney, they just need to rotate out here in Christchurch, and they'll get all the foreign body removal they ever needed.
Yeah, I'm sure it's regional, right? We don't get much foreign body in inner city Washington, D.C.
Foreign bodies are in other parts of the body, not the eye. All right. Well, this is an issue that's got articles from everything. So the next article I'll talk about is called "Preparing for the Next Pandemic: Designing Resilient Information Sharing Systems in Acute Care." The lead author here is Jaskaran Baines, and they're at the University of California, San Francisco. I'm not going to get too deep into this brief report looking at, but it's worth looking at in the context of trying to create knowledge resources for clinicians in response to acute public health events. These authors describe, in a high-level way, their efforts to create, sort of basically at the seat of their pants in real time, an online resource and iPhone web app to disseminate data regarding COVID treatment and the initial and the subsequent redeployment of the same tool in response to the Mpox outbreak in 2023. It's primarily a story, but it provides links to their online resources as an example, along with figures showing the correlation between case counts and resource access. I wouldn't call their project necessarily a model to attempt to replicate, but I would note it is a very reasonable effort in attempting to create an online resource adapting to clinician knowledge demand. Whether this should be done at a local institutional level or as a national program, depends on the scope and the context of the information need. That said, even witnessing the relative local success of their project, it's safe to say the manner in which clinicians access knowledge resources has changed dramatically over the past couple years. Whether a local app would be able to elbow out institutional, professional society, or general medical large language model based resources remains an open question. I'm not sure people would be accessing the local app or whether they'd just be going straight to Open Evidence or Docs GPT or something else these days.
Yeah, I mean, it was hard to even kind of tell how successful this was, right? They were just like, a certain amount of people access this app, and it increased when, more people cared about it.
It's a story of what they did and how they tried it and what they observed. So it's something to read and learn from if you're part of the group that creates knowledge resources for your hospital.
Yeah, it's like, how do you disseminate information to your clinicians? And despite having more and more access out there, more like global apps, there is always a value to having, local institutional information that can be disseminated in a way, because there's always stuff that, you want to disseminate that pertinent to your local group. And, I mean, like having a website that everyone knows go to check what's going on is probably useful, but it's probably not, the only way that it can be done, right? Like you can do this through like pop-ups, recorded like little lectures, there's lots of ways that you kind of try
embedded as decision support and alert.
Yeah.
You have an alert in Epic. But yeah, I mean, if you go to Open Evidence and type something in about Mpox, it's going to give you a whole bunch of information. It's not going to give you the phone number of the clinic for which that patient needs to follow up with and the phone number of the pharmacy they can call to get whatever drug they may or may not work. So it's just local resources are super important. And this is an example of they're just telling their story.
Our next article, Continuing Violence from Out of Hospital Setting to the Emergency Department and Hospital, a cohort study on longitudinal violence in healthcare. So obviously we're all fairly aware and probably have experienced workplace violence in the emergency department. But these authors kind of wanted to make point that this violence is not isolated to the emergency department. And often this violence starts in the pre-hospital environment, moves to the emergency department, and then moves to the inpatient setting. And that we have to kind of figure out the risk of these things, what are the potential causes, so on and so forth. Better understand it as its totality rather than isolated. They essentially did a retrospective cohort study examining violence across settings, and they looked 3 settings: out of hospital setting, the emergency department, and then the inpatient hospital setting. And they did this looking at patient records in the out hospital setting, and then in the emergency department, and then the inpatient setting. They looked at EMS documentation and then the EHR for workplace violence, which was recorded in a few different places for the emergency department and the in-hospital setting. So the data is a little kind of confusing. They don't have like equal amount of patients from each setting, nor do all these patients. They don't always track one patient throughout their whole hospital stay. But what they did find was 206 cases of out-of-hospital violence encounters, 868 cases of ED violence encounters, and then 3,561 non-ED inpatient violence encounters. And this represented 2,251 unique patients. So obviously there is some crossover, but not each one of these patients are followed throughout. Patients under 18 had a higher rate of verbal and physical violence compared with patients older than 18, whereas patients greater than 65 had higher rates of unspecified aggression, agitation, and confusion. And then reports of violence were more frequently for patients greater than 65 on the general hospital floors in the ICUs, where patients under 18 had more incident of violence in the emergency department and the inpatient behavioral health floors. When they looked across their patients, they found that there was continued violence throughout various settings. So 21.8% of the patients had continued violence into a second care setting, whether that's from pre-hospital to ED or ED to inpatient. They don't really state. Then 12% had continued violence into a third setting, and 7.5% had continued violence to a fourth setting. And they described nearly 1/3 of these patients remain violent across multiple care settings. So their whole point here is that it's not isolated behavior, and can change independent of or can occur independent of the setting you're in. I think there's obviously some limitations here. I mean, most of this is really based on whether the violence is reported or not, and what is the actual threshold that someone is going to report violent. That's not necessarily the same in the pre-hospital, the ED, and the inpatient setting. It may very well be that the inpatient setting had the most incidents of violence simply because the threshold to report violence was much lower than in the chaotic of the pre-hospital, where you just want to get the patient to the hospital and we don't need to report this violence. It happens all the time. And so it's a little hard to kind of truly quantify the incidence of this. But, I mean, there is some face validity that, patients that have a tendency towards violence, there are specific things that agitate them. And, those things don't necessarily go away when you transition from a pre-hospital emergency department and then you transition to an in-setting.
Yeah, I mean, I think that point about underreporting in the hospital and emergency department is pretty valid. And I think actually not just for our own sakes, but probably should document better and report it better, because then that information can flow to the subsequent wards where they're, to be honest, they might be getting a little bit blindsided by some of these patients showing up and not knowing how agitated or potentially violent they may have been back in the emergency department or in the pre-hospital setting. And then, of course, not just to protect ourselves, but which is actually turning into an EMTALA violation. Did you see that article the other day? There's a whole string of CMS reporting allegations for those no violence, like violence is not acceptable in the emergency department, because telling people that violence is not acceptable in the emergency department might discourage them from seeking care and receiving a medical screening exam. So there's concerns about EMTALA violations by discouraging violent patients from accessing the emergency department. So it's
yeah, I mean, it does
chaos.
get, there is questionable times when, there's a patient that has a history of pretty severe violence. Maybe they've even assaulted someone in the emergency department. And the question is, what do? You still have to evaluate them and make sure they're okay. But, you also have to staff. These aren't easy.
Unavoidable tension between those two mandates. All right. And then there's a small section of brief research reports looking at gender and ethnicity at the end of this issue. And the first we'll talk about is entitled Gender Representation Among Invited Physician Speakers at National Emergency Medicine Conferences. And that looks at the last couple years of physician speaker gender. Again, using our favorite tool, genderize.io, which just guesses the gender based on your name. But I digress. What's particularly lovely is that after having reported on this topic a few years back and seeing improvement but persisting inequity, in 2022 and 2023, the gaps are further closed, and women are actually better represented at SAEM than men, while a small excess of men remain at AAEM and ASAP. I am guessing that when we report back in just another couple years, we may see further elimination of any gaps. And the second is a research design-oriented article looking at whether there is agreement between reported Hispanic or Latino ethnicity and the defined Hispanic or Latino countries of origin, which is Mexico, Puerto Rico, Cuba, and then Central and South America, along with a few other Spanish groups. They found that only 70% of persons in a regional health system reporting Hispanic or Latino were actually from one of those countries. And that 70% inches up to 73% if you include Brazil and some Caribbean countries. This goes primarily towards informing the utility of self-reported ethnicity of variables when conducting research.
Yeah, I mean, I think this is great. The first one, obviously, this is a big improvement over the last time we did this, and a few years probably do it again.
I mean, we've been doing this for 10 years, and I think they were awful when we stared.
True.
And now they're even or almost even. So
yeah.
Massive progress.
Yes, and and we can only keep working, because obviously this is not something that just happens. This is something that has to work. Now, I would just add that the validity of Genderize is not 100%. I just put my name in it, and I was told I was 64% chance being a female. So
no,
yeah. So it's certainly not perfect. There is flaws in it, so we don't know exactly how equal this is. So
you're flying around and talking at all these conferences and skewing the female numbers positively.
Yeah, exactly. There may be still work to do, but obviously
Well, it's likely misclassifying a few people on both sides, and hopefully that's a similarly equal misclassification on both genders.
We don't know. I mean, we'd have to look at better, we probably have to do a study looking at the validity of gender.
Please don't. I'm sure that study exists already, and it's probably good enough that they are valid in using it. All right. Is that it?
That is it.
We've completed our
10-year anniversary.
10 years. So I guess the feedback we're looking for is, do you want another 10 years of Ryan and Rory, or do you want
new voices? We should say thank you. It's been great. And you guys there was a lot of patience, especially at the start when we kind of figured out how to do this. And, we had many iterations of improvements throughout that time, including me having to do all the podcast editing. I think there was a time when I was podcasting from like a dingy basement or a closet or something like that. And so thank you.
You got a nicer basement now.
Yeah, we've moved up slightly in the world. We appreciate everything. And we hope that 10 years from now, we'll be able to do this again. All right. On that note, this was Rory Spiegel and Ryan Radek, and this was the Annals of Emergency Medicine podcast.